Hello. Well, I'm Dr. Jordan, as Linda so graciously introduced me. And what I'm going to do is get started with the thing we're all here for, is the presentation to learn about antipsychotics, okay? And the geriatric population. So this is a very, very important topic. This is something that you're going to see in your everyday clinical practice, and it's something that is an area of debate in the field of geriatrics and also how we manage patients. So, as we introduced, I'm from the Wolk Center. And this is just the title of the paper. I mean, not title of the presentation, but also what's important: antipsychotics and geriatric and dementia patients. And this is just how we get started, okay? So the objectives, I know these were sent out. We'll discuss strategies for the use of antipsychotics in elderly and dementia. We'll also understand the challenges of treating dementia and geriatric patients, understand the types of antipsychotics, understand the roles of antipsychotic and treatments in these populations, and also non-pharmacological treatments in these patient populations, since this is a very large subset. And I mean, as you can see from the slides given to you, is quite a large area. And some of the things I will do is kind of skim over it, but this is more just so we have the base knowledge of, we can, since everyone is coming in from different perspectives and backgrounds, I wanted people to be able to have some general knowledge when I talk about some of the topics, okay? So the first thing we're going to focus on is, what is geriatrics? Because that is a concept that people think is defined by a number, but it is not. Geriatrics is not something that we determine simply based off of age, but it focuses on the care of elderly people, meaning there's no set point that we consider a patient geriatric, meaning you can move the point from someone in their late 40s can be considered a geriatric patient just because it's based on the patient's individual needs and the severity of immobility and other cognitive issues that we associate with it. So that is one thing that we have to really focus on and understand is, what is it and who is this patient population, because it actually is going to affect quite a bit of the people we see. So, and one of the important things of the geriatrics from the general population is because their geriatric population normally has a lot more what we call comorbidity or physiological differences. And so some of the big physiological differences you will notice are the decline of various organ functionings is something that we say. So that can be anywhere from your lungs to your kidneys to your digestive system to muscle mass. So it can be quite expansive. And so it affects the whole person. And so that's what we kind of determine what we're looking at when we consider, is a patient a geriatric patient or not. And so it talks about ways that we look at the appearance and kind of the remaining health reserves and organs. And that is something that is very complex and very far reaching, but we'll discuss it a little bit further. So one of the things we try to do, and one of the examples, like we say, is there are treatments for in the elderly population for diseases and effects of normal aging, because that is very important to see. So the example given is renal impairment or decreased kidney function is something that we see pretty frequently, but kidney failure or not being able to produce urine or being incontinent, meaning you cannot control the flow of it, is something that we do not consider part of healthy aging. So our goal is to distinguish what is the parts of normal aging and what is healthy. And so we want to give patients in this subset the highest chance to get the best quality of life at this point, and also preserve function and make sure that we're doing the best services for the patients. And so this is more what geriatrics is. As I mentioned before, we consider increased complexity, okay? And that just means there are different levels of what we would say wear and tear on different types of organs, because unfortunately, organs cannot continuously regenerate back to the new, a new set in time, even though there's research into that involving stem cells that is a little bit off topic, but it is something that is not achieved. So unfortunately, everyone is going to age and continue to age. So with this and with the aging in our population, there's what we call less reserves and less physiological ability to bounce back. And I'm sure that most people have experienced this in some form or another. I mean, people can consider when they're younger how limber and how they can do strenuous activities and nothing happen. And then you get older, and even as myself, when you start doing things, you're like, man, my back's really hurting, or I can't eat as much spicy food late as night, because your body is responding based off of the physiological reserve. And so in our geriatric population, we see problems that you would normally encounter in a normal healthy adult, which wouldn't be an issue, but in the geriatric population, they can compound and cause more issues, as you've seen, especially with this group that works with the geriatric population. So the example is there's fever in an elderly person, which can lead to confusion. Now, as we know, like fevers in non-geriatric patients wouldn't lead to this sequela or disease process. But because of the limited physiological capacity of the body and certain ages, it leads more towards a more severe and extreme response. And that is one of the things we have to look for in the geriatric population, is that they're most likely going to respond more severely to normal stressors in the non-geriatric population. And so one of the things that we also have to look at is polypharmacy, simply because most people who we consider geriatrics have several comorbidities and several different medical conditions that we have to treat and make sure that the medications are not interfering with themselves or causing the patient more harm than benefit. Now that is extremely important, hence the topic of antipsychotics in this population. And so also, like I say, there's also things that we can do as non-pharmacological or non-prescription based treatments, such as self-prescribed herbal medications or over-counter, which do have effects on the way people metabolize different medications and drugs. So they are not. And it found, and this is just one of the studies is referenced, all the references are at the end of the slideshow. But in one study, it was found that non-prescription medications were commonly used together among older adults. But you found within 1 in 25 individuals were particularly at a high risk when it came to the geriatric population. So this is one of the things and one of the reasons that it's kind of very important to recognize the whole health of this population. And these are more just things that the geriatric population presents differently than the non-geriatric population. And you have things such as pneumonias can cause deliriums or altered mental status, which are things that we see that often would present in a non-geriatric population. And also difficulty describing things because of confusion and cognitive impairment. So, and this is just one of the things that we kind of do, and Linda mentioned this early actually in her assessment, is we look at the functional abilities and the independence and the quality of life for the geriatric patients, because that is something we definitely want to focus on, because we want them to be able to live independently as long as possible. And when they need the care, be able to give them the care so that they can remain some activities of daily living. And normally in the geriatric field, we're able to provide information about elder care, home cares, skilled nursing facilities, assisted living, and hospice if appropriate. Now, and this was just a paper that is very interesting, and I took tidbits of it just from the understanding of the geriatric population. So we call this frail people. And so there's an assessment that we do, and the study just showed how geriatric patients, because frail people associates with the geriatric population. So we look for post-surgical complications and need for extended care, and actual prediction based on validated measures rather than just looking at a patient and saying, hey, this person will be fine outside of the hospital. And this one was related to surgery. And it was interesting just because they were able to accurately measure based on using these 5 scales of frailty, unintentional weight loss, muscle weakness, exhaustion, low physical activity, slow walking speed. Now, a healthy person or non-geriatric patient could score in a 0. Very frail person scores in a 5. And so with this population, we look at compared to non-frail elderly people, people with frailty scores of 2 or 3 are twice as likely to have post-surgical complications and spend 50% more time in the hospital, and are 3 times as likely to be discharged to a skilled nursing facility instead of their homes. So these are things that we look at that are relatively simple, but that simple checklist, as you see, is able to predict lots of outcomes for these patients. And as we see, even when someone scores a 4 or 5, they have even worse outcomes and normally do not end up going home, and normally have, as it says, 20 times the rate of non-elderly people being discharged to a nursing facility. So the ability in your body's plasticity is very important. And that is more just why we're concerned about our geriatric population, just because they're a very complicated population. There's a lot of things that we have to account for and treat for, and a lot of nuances to their treatment of care. Now, also, the title, one of the focuses of this paper, and we're going to pivot a little bit, is dementia. And by no means is this an all-inclusive discovery of dementia and all the pathophysiology about it. It's more just to give us on a general basis of what is dementia and how it looks. So as we see, dementia is not a single disease. It covers a wide range of medical conditions. The most common one would be Alzheimer's. And then we kind of branch out from there. And one of the things that we notice is it's caused by abnormal brain changes. And these can trigger declines in thinking skills or cognitive abilities that impair daily life and independent function. They also can affect behaviors, feelings, and relationships. And so Alzheimer's disease accounts for about 60 to 80% of the cases. Then we have vascular dementia, which occurs because of bleeding and blood vessel blockades in the brain, which is the second most common cause. And then there's also what we call mixed types, which could be caused by a genetic component or a vascular component. And there's also other things that can cause cognitive or dementia states based on hormones, vitamin deficiencies, and thyroid. And so one of the terms that you may hear referred to is senile or senile dementia, which affects the belief that it is a serious mental decline, but that it's a part of normal aging, because dementia is unfortunately not a part of normal aging. So this just goes into the types of dementia. Moved a little too fast. Back to this one. So Alzheimer's being the most common, frontal temporal dementia is a rare dementia. And it's associated with the form of tau and T33, and then you have Lewy body dementia, and it seems this slide does not want to stay, but we still get into what we call the different types of it. And like I said, this is by no means a detailed definition of all these different types of it, but this just shows vast array of what we would consider dementia. And then, as we mentioned earlier, dementia mixed types is either more from Alzheimer's disease or Lewy bodies or vascular dementia, frontal temporal dementia, Parkinson's or Huntington's disease can also lead to forms of dementia. So what are signs and symptoms of dementia? And the signs of the symptoms of dementia can occur when once healthy neurons, nerve cells in the brain stop working and lose connection with other brain cells and die. While everyone loses parts of this as they age, people with dementia experience that at a far greater rate. And this is just a lot of it just because it's more all-encompassing. But these are things that we all associate with experiencing with dementia: memory loss, poor judgment, confusion, difficulty speaking, understanding, expressing thoughts, wondering, getting lost, repeating questions, taking longer to complete normal daily tasks, loss of interest in normal daily activities or events, even hallucinations, which is something where antipsychotics come into acting impulsively, not caring about others' feelings, and loss of balance and problems with movement. So as you see, there's a wide range of things that could be seen with dementia. And how it's diagnosed is we first assess whether a person has an underlying potentially treatable cause or condition that can lead to these cognitive difficulties. So measuring blood pressures, vitals, also checking thyroid levels, hormones, and vitamins to see if any of these can lead to it. Because as we saw earlier, there can be several causes of dementia besides simply Alzheimer's or vascular dementia. And then also a detailed family history, a review of medications. I mean, not review of medication, review of family history can lead to better answers if there's a genetic component to it or not. And if someone is taking medications, if they can be helpful or not in patients with dementia. And there's also other procedures that we can use to help diagnose dementia. Some of those being cognitive and neurological testing, and those are just tests we use to assess functioning and thinking, and also tests for memory, problem solving, language skills, math skills, the whole gambit, essentially, sensory and balance loss. And then also we can use brain scans to see if there's some identifiable cause of it, simply looking for tumors, vascular problems, brain structures, and the different types of brain scans we use: CT scans, which are just X-ray images, MRIs, which are magnetic field views, and they give you a more detailed image of body structure, including tissues, organs, and bones, and then positron emission tomography, or PET, which actually is a great way to see brain activity. And all these could be used in combination or individually, and we mentioned earlier, even getting lumbar punctures to confirm different types of dementia. Then also we do psychiatric evaluations, because depression often in the elderly population and geriatric population can cause a lot of the symptoms associated with dementia, such as confusion, slow thinking, decreased energy level, issues with sleep, frailty. And so we have to make sure that the patients aren't experiencing, so psychiatric evaluations are important. Genetic tests, as we mentioned earlier, getting the family history, and then also blood tests. And as we say, you can get a lumbar puncture, or you can get a blood test to measure beta amyloid. And that is normally for a specific type of dementia, which is Alzheimer's, because we don't want to lump them all together just because there could be so many different causes of dementia. All right, and then just we mentioned earlier, but this is, we just can find several changes associated with Alzheimer's, which was kind of, or dementia, which can kind of be, was addressed earlier, but this is just a reminder. However, sometimes medication, environmental influences, medical conditions can also make those symptoms worse. So for some of the treatment strategies that we use for dementia, the first thing we try to do is do the non-pharmacological approach. And so many of these just help address the needs of patients with Alzheimer's or dementia and with difficulty as the disease progresses. And so we always, as a rule of thumb, try non-pharmacological treatments first. And so things that we look for are recognizing the patient is just not acting mean or ornery, or these are things that we look for to kind of help identify non-successful or developing treatment strategies for the patients. And as we can read kind of thing, identifying the cause of the symptoms that may relate to the experience with Alzheimer's, changing the environment to resolve challenges and obstacles of comfort, security, and ease of mind. And then one of the things we also like to do is monitor the person's personal comfort, because simple things like this can have a drastic change on their response. And so we do want to make sure that we're able to address their basic needs, such as pain, hunger, thirst, things like that. Also, avoid being confrontational, just because things associated with this are the decreased cognitive function and memory loss. We don't want to belabor our point, because unfortunately that really just causes more distress to the patient and doesn't actually help with the overall process of bettering the patient's long-term outcomes. And then also redirect their attention, because this patient population experiencing dementia has issues with memory. So remaining flexible and supportive and not being emotional, which is hard to do, but we have to realize that these patients are suffering with the disease process. So we have to better address this, not think that they're doing this maliciously, and then also creating a calm environment. And these are just simple non-pharmacological steps that we can kind of take to help with dementia and try to manage it. But obviously there is a pharmacological arm to us, and this is just more of the strategies we can use that we can take the time to go over. Just allow rest between stimulating events, provide a security object, acknowledge requests and respond to them, look for the reasons behind each action, explore various solutions, and don't take behaviorals personally, and share your experience with others, because it can be very lonely to deal with caretaker stress by yourself. And it can be very difficult, and we definitely want to make sure that as a caretaker or someone dealing with the patient population, that we don't burn out, and we also protect our own mental health. And so getting to this, we get into the medication management for it. And so there are medicines that are FDA approved, mainly for the class of medication they're approved for is Alzheimer's, but they work on a lot of dementia process. And so what they do is slow down the symptoms of Alzheimer's or dementia. And so drugs there's two major classes of drugs. The first class is diseases that we use to help slow down disease progression. And those we start early on patients. So we try to get them in early once we see the cognitive decline. And we want to help them maintain the highest level of function. Like I said, activimab is actually IV treatment, and that isn't, and so it's something you take intravenously, meaning you need an IV port, or not a port, but IV access. And so it works by targeting beta amyloid, and that is something that causes the plaques in the brain associated with Alzheimer's. And these plaques, that we can get further into detail, kind of disrupt communication between the nerve cells, and they also activate the immune system, that trigger inflammation and cause actually destruction of the nerve cells. And so there's obviously there's a lot of research and debate associated with this, but we do know that amyloid plaques is one of the major contributors to this. And this is the first therapy that is shown to help remove amyloid, which is one of the bases of Alzheimer's disease. And so it also helps with reducing the cognitive and functional decline in people living early with Alzheimer's. And so the key to that is to start it early. And so this is more about it, and this is just more about the studies associated with it. It was studied with patients with mild cognitive impairment or mild dementia due to Alzheimer's disease. And it just shows that it was safe in this patient population. But the caveat of this is, since this is something that affects the disease course, there's not a lot of studies that focus on what happens to it when you use it in the later disease stage. So what it is like a lot of medications, it is preventive. So it can help stop the buildup of amyloid plaques, but we don't know if it actually ends up reversing, especially in the more severe stages of Alzheimer's. And this is just more about some of the measures they were able to find, including memory and orientation. And these are just personal things when we talk about activities of daily living and quality life. Being able to conduct your personal finances, a big area among this patient population, and also performing just everyday activities. Now, one of the things that we have to do is look for, and this is maybe a little out of scope, but ARIA is just something that we look for, and that's amyloid-related imaging abnormalities. And this can fall into several different aspects, but it is a common side effect, but it's not usually cause symptoms. This is something that you can see on imaging, but it does not actually require treatment immediately. But it's just something that we know can happen with this medication. And then we have the drugs that are used to help with memory and thinking. So these don't actually affect disease progression. These are actually just to help with the symptoms of the disease. And so these are your cholinesterase inhibitors. And so, as it says, these are used to help with memory, thinking, language, judgment, and other thought processes. And they break down acetylcholine, and that is a chemical messenger that is very important for memory and learning, and also communication among the cells. And Aricept is the most common one, but we have all sorts of different ones. And this is the purpose of this information is just for you to have some reference to when you see these drugs prescribed in this patient population, what they're trying to treat, what's important. By no means is it important that we know both the generic name and prescription name, but often just focus on what these help treat in this patient population. And then, like I say, other things that we do are glutamate regulators, and these help with memory, attention, and reasoning. Like I said, the Menda is the big one, and this just works on the activity of
Dr. Jordan, it looks
associate.
Go ahead.
And these are just some of the side effects that we can see associated with it. And then there's also medications for non-cognitive treatment of dementia. And this kind of leads to the area of focus that we're going to look at into. And so there's medication. And Belosomar is actually a very interesting medication. There's a very interesting story on it. But this is actually one of the few medications that is actually FDA approved for patients with dementia and Alzheimer's disease. And then there are several medications as we get into that have off-label use for dementia and the different subtypes of dementia. And that's kind of where we get into for the majority of the drugs we're going to work with, especially with antidepressants. This is just a list of antidepressants that we can kind of use in this patient population. Now, like I said, this is off-label, meaning there's no FDA approval for these in this patient population. There's no studies saying that these are specifically for dementia patients. These are just drugs that we use to help with anxiety, depression, disruptive behaviors, and resistance. So it is important because the main focus of this is also antipsychotic medications. And we use antipsychotic medications for hallucinations, delusions, aggressions, agitation, hostility, and uncooperatives. But, and this is just a small list, we'll get into a further list. But the important aspect of this is these are all off-label uses of these medications, meaning no antipsychotic has FDA approval for treatment in dementia. Now, there is treatment in the geriatric population, but also that is off-label as well. And that's just saying that the FDA has not found any significance in this patient population, and we'll kind of address that later on. So this is a very popular ad that I've seen multiple times. It talks about Thorazine, which is a older antipsychotic that we use when patients who have failed multiple treatments. But it's just interesting because the way they look at it, or the way they view it, is a way to, calm and sedate patient. So the interesting thing about antipsychotics is they were actually found by accident. And so the first one was actually a surgical anesthetic, and it was used on patients to calm them down. And it's, as they say, they used it as a non-pharmacological lobotomy. So this occurred in the times where lobotomies is actually one of the preferred treatment options for non-combative patients. And interestingly enough, lobotomy actually won a Nobel Prize since it was considered so groundbreaking. But this is how this is one of the names that they use for it, and it was chlorpromazine. And that was helpful in being able to stabilize patients and also treat psychosis. And so this is kind of the first antipsychotic we discovered, and it kind of branched off into the field of antipsychotics for behavioral disturbances and things like that, because the first uses of these were actually for calming and sedating patients. Their first uses were not for treating psychosis. And so that is something that kind of pivoted and shifted once we learned more about the causes of psychosis, delusions, and things like that. So one of the things we want to focus on is talking about the mechanisms, actions of antipsychotics. So we will, and this will get into this a little bit later on, because this is the bulk of the conversation, is the different types of antipsychotics. So a lot of you may be familiar with Haldol. I mean, it is one of our oldest and most typical antipsychotics, but it's what we call non-selective, meaning it blocks dopamine at the D2 receptor very, very heavily and non-selectively. And so that means that in patients with agitation and psychosis and things like that, we find that they have higher levels of dopamine, and this blocks that, which causes that calming effect. And so one of the things that it works on is the mesolimbic pathway, which we'll go into that a little bit later on, and that is associated with psychotic experiences. And then we also have decreased dopamine release in the prefrontal cortex and excessive dopamine and other pathways that are associated with psychosis and schizophrenia. And then there's also the antagonistic effects of dopamine, in particular atypical. And so atypical means second generation antipsychotics. So first generations are non-selective. Second generations are definitely more selective. So they also antagonize, we call the 5-HT2A receptor, and that's our serotonin receptor. And these receptors have been found in patients with schizophrenia and other types of psychosis, and also depression. So that's why a lot of the newer antipsychotics have antidepressant effects as well. And we have a lot of locations in the prefrontal cortex, but also the caudate nucleus and things like that. And so we're going to get a little bit into it, and this kind of refers to it as the typical, which is your older antipsychotics are not particularly selective. They block dopamine receptors in the mesocortical pathway, tubular infundibular pathway, and nigrostriatal pathway. And so these also produce side effects by the pathways that they block, and this is something we'll get into. And then there's also terminology that they use associated with antipsychotics, such as low potency to high potency. And that is simply, as it says below, the ability to bind to dopamine receptors and not to the overall effectiveness of the drug. So simply because a drug binds heavily to the dopamine receptors does not mean that it is a better acting drug. And one of the things is examples. So we have one of the older typical antipsychotics, antipsychotics, haloperidol, essentially is a high potency because it binds the D2 receptor at a high frequency. And then you have lower acting or lower potency antipsychotics such as chlorpromazine and thorazine, which doses are a lot higher, but they also affect different pathways such as your anticholinergic and antihistamine pathway. And we'll get into all these side effects a little later on. And this is just talking more about what I mentioned earlier, atypical or second generation antipsychotics. They block the D2 receptor, but they also have been found to block different serotonin receptors, which gives them their antidepressant benefit. And then there's Plozaril and quetiapine are also Seroquel. And this is just some of the side effects that are associated with these medications, but I'm going to address this on a further slide. So this is getting into the dopamine pathway, and I apologize, it was supposed to be a lot larger, but we have the neurostriatal pathway, okay? And so that's where we see this path right here from the substantial nigra to the striatum, and that's important for motor control, death in neurons, and this pathway causes Parkinson's disease. So normally this is associated with movement. Then we have the mesolimbic and mesocortical pathways, and that is associated with the ventral tegmentum area to the nucleus accumbens, the amygdala, the hippocampus, and prefrontal cortex. So you see that you have these different branches here as well, and it goes all the way into the prefrontal cortex. And this is in charge of memory, motivation, emotional response, rewarded desire, addiction, and also can cause hallucinations and schizophrenia. And then you have the tubulin infundibular pathway, and that is simply the hypothalamus to the pituitary gland, which is important for hormone regulation. And it's something we find in maternal behavior, pregnancy, and sensory processing. So this is the pathways that are affected by the dopamine blockade. And then we get into, and this is just the list that I was mentioning earlier, we have what we call first generation antipsychotics, and you have both the brand names of the medication and the generic names of the medications. And so you see quite a bit with Haldol, being haloperidol. You know, a lot of these drugs, especially the older first generation antipsychotics, are not very commonly used. But then we get into the second generation antipsychotics, which is something that we use a little bit more, such as your Risperdal, Invega, Zyprexa, which is olanzapine, Seroquel, which is extremely common use, Geodon, not so much, Latuda, Abilify. And these are the second generation antipsychotics. And as we remember, these selectively blockade the D2 receptors, but also affect the serotonin receptors. The first generation mainly focused on simply dopamine blockade. And so this is talking about the dose equivalent to chlorpromazine. And so as we can see, we go from high potency to low potency. And the interesting thing about this is Seroquel, which is a very common drug, is actually one of the least potent antipsychotics we use. And when I refer to potency, I'm referring to the ability to bind a D2 receptor, and it weakly binds the D2 receptor. And so it also has a very short half-life, which is interesting just because you have to dose it normally to be effective multiple times a day. Right. Slide. And here is another list of the psychotics, just because this is something that is very important. It's one of the focus of it, and it gets into more of a detailed explanation of what is dopamine, D2, what area does it have a high affinity for, and also some of the side effects associated with these, which we're going to get into a lot further. And it also shows things such as high potency and atypical, and it kind of is just a reference guide for the different types of antipsychotics. And so this is just something kind of to give you a visual of the mechanism of action and how antipsychotics work. And so you see that there is dopamine blockade essentially on the D2 receptors, and that's on the postsynaptic neurons. And so as you see, you block 2, you decrease psychosis or other side effects that we're concerned about. And this just goes into more just to give you the mesolimbic pathway and also the mesocortical pathway. And it talks about these are atypical or second generation drugs and how they block the D2 receptors and the side effects that are associated with it, meaning positive symptoms. When we talk about positive symptoms, we're referring to psychosis, meaning delusions, hallucinations, auditory and visual. When we talk about negative symptoms, we're often talking about cognition. And so that's something that you see is different with atypical antipsychotics because they work on the serotonin receptors. Now, the APA actually has guidelines on the use of antipsychotics in this patient population. And before, we always have to see if there's more risk or benefit to this patient by using this. And obviously with the patient population, we have to determine if the patient is capable of making this, if they have a surrogate decision maker who can help with this process. And so we recommend that we use non-pharmacological treatments before to see if there's any way we can do it. But if we do have to use antipsychotics, one of the things that we do is we start with the lowest dose or the most minimal effective dose. So you never start off with the highest dose possible in this patient population. And also we want to make sure that we're not clinically harming the patient, hence why we start with the lowest dose of it. So we should determine if once they are stabilized on the lowest dose possible of the medication, if we should begin tapering and or discontinue the medication altogether. And so one of the things that I recommend is that if there's no clinical significant response after a 4-week trial of an adequate dose of antipsychotic, then the medication should be tapered and discontinued. Now, this is important just because we often see patients who are treated indefinitely with antipsychotics, and that is actually against part of the guidelines associated with it, is that we want to use the lowest dose as possible, but we also want to try to get off of them as soon as we can, just because, like I said, this is not an FDA-approved medication to treat these things. And as we'll see later, they are not extremely beneficial for this patient population. But in the acute settings, they can be helpful in controlling behavior and agitation, but they are never meant to be a long-term solution for behavioral control, simply because they do have so many side effects and issues associated with them. So psychosis and agitation is one of the most common things that is tried to treat. And as you see, this number is 80%. And as I stressed before, there's no FDA approval. And there's actually a black box warning for typical antipsychotics for people with dementia. And one of the most studies show, and most things that we understand, is that there's modest to no benefit in patients when managing aggression or psychosis, but there's an increase in severe adverse events with this medication, hence the black box warning. So, and this is just what we look at and when we see medication trials, that the power of the medication is not potent enough to warrant the intervention at times, or especially with long-term use, hence why the guidelines essentially are saying get them on the lowest dose possible and get them off the medication as soon as possible, just because with increased use and increased dosage, we find serious effects, serious adverse events associated with it. So, like I said, this is just belaboring the point that they should not be routinely used to treat aggression and psychosis, and mainly in cases where they are in severe distress or risk of physical harm to others. And so this is one of the things, that's why they focus so much on psychosocial interventions, because as you'll see in 2005, this is when they issued the black box warning, and they said there was an increased risk of death when atypical antipsychotics are used in dementia. And that is a very, very big thing for them to tell and say that, hey, these drugs may control the patients acutely, but we notice very serious outcomes and long-term effects with these patients. And then since that time, since 2005, there's been a drastic drop in the use of antipsychotics to treat dementia for that reason, but they're still very prevalent in treatment today. And so one of the things that we looked at is there was a large meta study that looked at the use of atypical antipsychotics in individuals with dementia. And those are the ones, risperidol, Zyprexa, Abilify, and they show there's modest efficacy in treating psychosis, aggression, and agitation in that patient population. And they also saw that there was limited use with Seroquel, because Seroquel or quetiapine is a very common drug as well. But these symptoms were better treated with atypicals as opposed to typical medications, because normally we shy away from typical antipsychotics with these patients. But it does have some modest efficacy in individuals with dementia, but there's no differentiation between any particular drug or the first. So the take-home point of this is, because it sounds like a little contradictory, but we use antipsychotics when we don't really have any other options. And they're effective for severe symptoms, but they also, at higher doses and longer use, lead to worse outcomes, including mortality and death. And that is something that is very, very important to take away from this, is they're appropriate in small uses, but not something that we can use for long-term treatment solution for patients. And so this is just kind of reiterating what they're going on. And this is just a valid point that is very interesting, that there are no actual new meta-analysis with the newer atypical antipsychotics, such as Geodon, haloperidol, Saffris, Latuda. These are the more common names of these in dementia. And so there's not really a lot of evidence for use with this in the dementia population. So that is normally why you will rarely see these medications used, if ever, in these patient populations, unless they have an underlying psychiatric diagnosis that requires the use of that. And then we get into the long-term effects and the reasons that we want to stop it as soon as we can. And so the long-term effects, we see they have decreased life expectancy with the use of antipsychotics. They also increase the risk of early death in dementia early death in individuals with dementia. And then polypharmacy, as we mentioned way at the beginning, is something that we have to make sure, because especially with antipsychotics, since there is no FDA approval for it and it's off-label, and there's decreased life expectancy and early mortality associated with it, it's not something that we want to combine. And so hence the guidelines are lowest doses, get off of it as soon as possible. And also, as we can kind of imagine with these medications, since they are sedating and powerful, they can lead to adverse cognitive effects. And then, like I say, they keep stressing, and it's important that they have been found to increase risk of death in people with dementia, along with worsening symptoms and long-term treatment. Why these are not drugs we want to keep patients on long-term. And then some of the more physical effects are loss of gray matter. There's also atrophy associated with these that we see. And so essentially what we see is these brain sizes compared to patients who are not on antipsychotics who have dementia are actually smaller with chronic antipsychotic use. And that is bad just because, as we talked about, organ reserves, as you can imagine, the smaller the organ is, the less reserves there are. And so if you're using a medication that further shrinks it, that could lead you to understand that there's not much reserve or treatment left in that, and a lot of cognitive reserve or plasticity associated with that. And this is something that you see, and I was just talking about the fact that atypical or typical are associated more than atypicals, hence why we use anti-atypicals or second generation medications more frequently. And so this is just something that is just reiterating the point, even in animal models, that we see decreased brain volume with this. And then also there's also long-lasting forms of akathisia, which are looked over, and then confusion, post-psychotic depression in patients. So there's a lot of side effects associated with these drugs. And so one of the things also that they found in meta-analysis, that patients who use first generation or typical antipsychotics have an increased risk for stroke, ventricular arrhythmias, myocardial infarctions or heart attacks, hip fractures, as compared to second generation. And antipsychotic induced stroke accounts for 6.7 of this difference. And then it just goes into the different numbers for this. And so, one of the other take-home points in the important part of this slide is first generation or typical antipsychotics have more adverse effects associated with second generation. And so, I mean, when you're looking at a 17% difference in mortality, or we just rounded up to 20, that is a pretty big range and cause of us to kind of stay away from those drugs. And then just to even further, one of the studies, they found that haloperidol or Haldol results in the highest mortality rates when compared to Risperdal, which is a second generation. And Risperdal, Zyprexa, and Seroquel. So typically we stray away from typical drugs, especially in dementia, just because they do lead to higher rates of mortality. And there is some debate, and this is what this slide is just for, is to show that there's always opposing opinions in medicine. And one of this showed that maybe if we look at the whole picture, that it's not just the use of antipsychotics that are causing these patients to have higher rates of mortality, but also there's the premise that the reason that these medications are used on these patients is they're more severe. And as you imagine, if you have a data set with more severe patients as opposed to non-severe patients, you would see higher rates of mortality as well. So this is kind of what this slide is kind of highlighting, is that these results could be skewed simply because the patient population they're used on is more severe. But like I said, there's no data that supports that, or that it definitively says either or. And then this is just a slide, and it's one of the pretty color-coded slides that I wanted to use just because it gets into the different types of side effects associated with it, with the different antipsychotics, and it focuses on atypical and typical. And this is more, like I said, a reference slide, and it has the chart at the bottom, meaning 3 dots means pretty frequent. 1 dot, 1 green dot, not so much. And so as you see, there's a wide range of side effects associated with it. But when you get into the typical antipsychotics, especially at the bottom, you definitely see a lot more of the higher frequencies of side effects. And we're going to go into these side effects as well. And so orthostatic hypotension, and what that is dizziness when you stand or walk from a seated position or laying in a bed. And that is something we see frequently, and that can lead to serious falls in these patients, and also hip fractures, which has a high rate of mortality. Then we have anticholinergic effects, which are dry mouth, nose, blurred vision, constipation, urinary retention. Those are managed symptomatically, and as you can imagine, if you're having issues with those in a demented patient, they can also increase the levels of agitation, simply because at times they can be altered and not oriented and can't tell you what's going on. And imagine going through these situations where you're not able to urinate, you can't see, and you're just getting more aggressive, and the medication that we're using to treat you is causing it to get worse. And then the big thing that we see is extrapyramidal side effects, or EPS. And so akathisia, as we see, is restless leg syndrome. But it's simply when patients have the inability to sit still. So you'll see them constantly fidgeting, constantly having to get up. They have an urge to move. They never sit still. That is something you see commonly. And then also in patients, we can call it dystonia or dyskinesias, which are grimacing, intermittent muscle spasms, oculogyrocrisis, or head and neck stiffness are very interesting, because in those situations, the muscles can actually freeze in place. So these people have fixed vision and aren't able to move their eyes or the muscles in their eye. So they just kind of stare at you, and it's very painful. And then also we can have the Parkinsonian side effects, or muscle stiffening, cogwheel rigidity, shuffle gait, stoop posture, drooling. And these, like I say, these medications are not benign, and there's just lots of side effects associated with them. And so this goes into tardive dyskinesia, and this is more associated with typical antipsychotics, and this is caused by permanent irregular movements that are involuntary, such as lip smacking, tongue protrusion, chewing, blinking, grimacing, rapid jerky movements. And this is something that is typically irreversible. And so that is something associated with long-term antipsychotics. And then we just have different treatments that we can use to treat antipsychotics, such as pentotropine. For antihistamine, we can do promethazine, Valium, lorazepam, things like that. And then some of these medications can even induce seizures in the population, though it is extremely rare. It is something that we do have to look for, and we also have to look for neuromodulation syndrome, and that is a very serious and fatal condition that requires ICU hospitalization, because it requires muscle rigidity, high fever, and essentially is what happens when the increased muscular enzyme CPK is when your muscles start to break down. It actually causes your liver to go into renal failure, and then you have leukocytosis, which is elevated white blood count. So that is a very, very, and one of the most serious side effects associated with antipsychotics that we kind of do. And then also we have the opposite, which can occur, which is always what happens in medicine, or agranulocytosis or low white blood count. And so that could be something that will make you what we would consider immune compromised if you have a decrease in your white blood cell count. And so this is just talking about a specific type of antipsychotic, clozaril, that requires weekly white blood cell counts, and there's a whole protocol behind it. And it is something we use mainly in patients with very severe schizophrenia, and not generally used in patients with dementia, but it is a side effect that could be caused with atypical. And then this is just another chart kind of to get behind the mechanisms of what causes these symptoms and what their features are, how quickly they occur. And like I said, this is more just a reference for your knowledge. And then obviously we have alternative treatments that we kind of talk about. And one of the big things they do are non-pharmacological approaches, and music therapy is something that we use that can kind of help, because some patients, when they're in an agitated state, playing music or a song can be something we can use to help redirect them. Some simple things as aromatherapy are things that we can use, common sense, because the goal of this, as we know, is to prevent the long-term use of antipsychotics in this population, just because it has so many negative long-term side effects associated with it. And then also pet therapy or animal-assisted therapy is something to do, or recording family videos or messages from family members are another way of calming and soothing patients with dementia. And that is something we can kind of use in these patients, and I've seen that work in real time with patients, and also pet therapy with extremely agitated patients. So all of these things are strategies that you can use, but they're just dependent on the patient. And like I said, if you failed these strategies, in antipsychotics come into play. And then also we specialize in our clinic is doing neuromodulation. And so we use TMS, or Transcranial Magnetic Stimulation, Alzheimer's disease. There are several studies on it. And right now, the mechanisms of action are kind of being found and sought out, and that's what we're doing. But the goals are to help with cognition and behavioral issues associated with it. It's something that we also use at the Wolk Center very frequently, and it's something we use for patients with depression as well. Now, it's FDA approved for patients with depression, but there's also it's FDA approved for OCD and migraines as well. And so that is something that our clinic, we're able to do, and it's something that we do more on an actual daily basis, and we can see how it's helpful in this. And one of the things that we're actually doing right now is recruiting and studying patients with Alzheimer's disease and using TMS as a treatment strategy to kind of help with the psychological and the behavioral aspects associated with it. Now with this, because I see it's going a little long, but we're already at the end, so the questions.
Thank you, Dr. Jordan. We do have a couple of questions that came.
Oh, I imagine there's quite a bit. Like I said, the goal of this was it covered a lot of aspects. I'm not going to act like this was a small topic by any stretch of the imagination.
So the first question is, why do these medications decrease life expectancy?
So that is actually why I went through the side effect profile, because that is something that we see. So you can imagine if you're having side effects in this population that already has decreased organ reserves, and all of a sudden now they get dizzy or sedated and they get out of bed and they fall and they have a hip fracture, or it causes sedation and somebody has pneumonia, it can cause increased risk of infection. And also you can see the drugs themselves can lead to increased risk of strokes, arrhythmia, myocardial infarctions. So with all those side effects associated with it, that can lead to an increased rate of mortality in these patients, because there's so many factors, because these medications aren't clean and simple. They're very complicated and they affect a lot of different systems associated with it. And so that is why, and that's what's like the take home of this message is, we use them, but they're not FDA approved and they have a lot of issues. And I can't kind of stress that point. There's a lot of issues with long-term use. And so we have to be very cautious with this patient population.
Thank you. And the next question is risk of stroke or MI.
Okay, and so the specific, now, as far as the actual mechanism of action for MI or stroke, for MIs, some of these medications, and like I said, I know we have a wide audience, what they do is they increase the QTC, and that is just the electrical rhythm of your heart. And so what happens is you can elongate that with some of these medications, and that causes arrhythmias or an irregular beat of the heart that can lead to a heart attack. And that can also subsequently lead to a stroke, because when your heart doesn't beat correctly, what happens is your heart keeps beating, but blood is not pumping through because it's desynchronized. And that, like I say, that's a whole other topic. But you can end up throwing clots into vascularization from the heart when it starts beating correctly, because the blood is pooling there and it's not going anywhere. So clots form, then all of a sudden your heart starts beating normally, a clot comes up, causes a stroke, or it can cause an arrhythmia associated with it. So, and those are side effects that we know occur with it, and we monitor for that.
The next question, excuse me, is what are your thoughts on using, forgive me for pronunciation, dronabinol for dementia patients?
So with that one, there's not a lot of evidence supporting the use, and it's more symptomatic, meaning if you find that it's effective in it, it's definitely not FDA approved for it by any stretch of the imagination. So it is something that, like I say, would be an off-label use for the medication. So that is something we have to take into consideration, because as you saw, the entire list of antidepressants was off-label. Meaning, so there's no rhyme or reason to off-label use. You just have to understand there's no proven benefit when you're using these medications. So you're assuming that risk when you're using these medications.
The next question is, what do you do to handle ongoing hallucinations that continue when antipsychotic med is discontinued?
And so that, like I said, I've covered a lot. And that gets into the deeper overarching question of what is the cause of the psychosis. Because dementia can have episodes of psychosis, but generally that is not one of the prominent symptoms. And we also do have patients who have psychosis associated with other diseases, even with schizophrenia, who we use these medications for. You just have to weigh the risk benefits. So are these non-bizarre hallucinations, meaning the person is not thinking somebody's trying to harm them, the person is not hallucinating and seeing things that are harming him. So when I say non-bizarre hallucinations, there's examples of people who have strokes in a particular part of the brain, and in particular vision fields, they'll see like a dog in the room. Now the dog's not doing anything and nobody else can see the dog, but it's a hallucination. And it's like, how aggressively do we treat that? So the question that comes down to is, what kind of distress is the hallucination causing the patient? Is it causing them distress? Because some people, and it's very common that we see patients with dementia who hear music, which would be considered an auditory hallucination, but how aggressively I'm going to treat your music unless you're not able to sleep at night because you're constantly hearing music. But some patients, and the majority of patients that I work with, are like, oh, it happens. It's not a big deal. And so you also have to gauge the severity of it and what you're treating. And like, if it's truly disrupting, you have to have a conversation with the patient. These medications are going to increase your rates of mortality. I mean, they're not particularly beneficial long-term, but if this symptom is so severe that we need to manage it, this is the option we have. And this is obviously after you use other non-pharmacological treatments as well.
The next question is, can you speak on cognitively challenged individuals?
Oh man, that's a whole nother lecture topic. It is oh man. I actually, in my prior practice to this, I actually worked with several cognitively impaired individuals, and the concerns are different depending on the cause of cognitive impairment. Because unfortunately, like I said, you can have genetic cognitive impairment, you can have traumatic brain injuries that cause cognitive impairments, you can have strokes. And so depending on the underlying cause is going to determine how aggressively it's treated. Because a lot of these medications you're for cognitively impaired, like I say, you're not focusing on improving the actual impairment. Is more for behavioral control as opposed to treating the underlying condition, especially with genetic conditions, traumatic brain injuries. And I mean, you're not really focusing on the underlying condition. And so the medications can be used behaviorally, but it also is the results of this are not specific to the cognitively impaired community, just because their age range, they don't fall into the geriatric age range. And so their side effect profile is a little bit different. And also the things that we're worried about are different when we're treating that population. I know it's a long-winded answer, but
Thank you. Any other questions that people may have? That might be it. So Linda and Dr. Jordan,